Good afternoon. I am Sister J.T. Dwyer, a daughter of Charity. And the Daughters of Charity are the founders of the Seton Healthcare family. And we're one of the largest employers in Central Texas with over 11,000 associates. We are also the founders of the Providence Healthcare Network, the largest employer in Waco. We have health clinics and wellness programs in San Antonio, Brownsville, and El Paso today. We were formerly in Dallas, Sherman, and a hospital in El Paso. We at Seton believe that basic health care is a right essential to human flourishing. This belief is tied to our stance that each human being has inherent dignity. Health care is essential to promoting and protecting that inherent dignity. Texas has an opportunity to bring the possibility of affordable, regular health care to low-income adult Texans by accepting the federal dollars offered through the ACA to this population. Over 1.5 million of our uninsured U.S. Texas citizens could gain coverage if you and your colleagues work successfully to find a way to accept the money that is on the table to do this. Will you choose to help this group and the people whose testimonies you've heard? Many of them work hard day in and day out, but their job does not offer affordable health insurance, and purchasing it is cost prohibitive. Many others suffer with needless pain. You just heard it. Needless pain, and studies show that several thousand Texans die each year because they did not have timely access to affordable care. Do you want this to continue when you have a chance to change it? If it was your brother and your sister in this group of uninsured, would you turn your back on this opportunity to bring them health care coverage? In fiscal year 2011, which is the last for which we have data at Seton right now, we did $350 million in charity care. I'm talking about direct charity care and unreimbursed Medicaid. This does not include community benefit or bad debt. We see caring for those in need, regardless of their ability to pay, as constitutive to our mission. Hospitals agreed to certain cuts in Medicare payments and changes in the DSH payments because at that time the ACA was going to provide that all U.S. citizen patients with incomes under 138% of federal poverty would have Medicaid. Thus, hospitals believed that they would get at least some payments to replace those cuts. However, when the court ruled, we know that they put it up to the states. They put it up to you all. Choose whether you want to do this or not want to do this. But yet, if the state says no, the hospital will continue to shoulder the financial cost of this uninsured population, but without some of the former revenue streams that made that possible. Will they be able to do that and remain solvent, some of your largest employers? Finding a way to bring affordable health care to these neighbors is not only a moral imperative and a financial necessity for hospitals, but it's also a fiscal win for the state, and you have many studies up there, the Hamilton and all those things that the other people have supplied to you. And I know that they will expand further on that point as you hear other testimony today. Thank you very much.
Well, thank you for being here. Do you have a comment? Yes. Representative Howard.
Hi, Sister. There was an article in the Austin American Statesman today that you may have seen that talks about the reconfiguration, restructuring of how Seton is going to be doing things, as well as other hospitals, because of the way we're shifting reimbursement and outcomes-based and collaborative delivery of health care. So this is what you're advocating for today is part and parcel of that whole package of shifting the way we deliver health care, is it not?
Exactly. And Seton has many wonderful pilot programs out there, and you know that Seton was the leader in this state over the whole neonatal and delivery of preterm births. Representative Colcourse, you've been very complimentary in the last session about Seton's work in that, and you're all well familiar with it. And we're doing that same type of things in other areas. At Brackenridge, we have what we call the frequent flyers. You know, we all know that about 80% of the health care dollars are consumed by 20% of the population. And we have a pilot program going through Brackenridge now where we have, in the loose term, navigators, not navigators as debated in the bill, but people who are helping a lot of these people who came. And, you know, when you look at what caused it, it was they didn't have transportation, so they couldn't get there to get their medicine. And the medicine would have kept them well. You know, so this is very complex. We're in a very complex time in changing the delivery mechanisms, and yet there's no cost reimbursement for a lot of the stuff we're doing at BRAC right now.
In fact, you mentioned the induced labor situation that y'all were leaders in, and you were not being reimbursed for making...
That's correct. We used to make tons of money on our intensive care units. It was permissible to deliver babies, you know, so the doctor could go on vacation. Let's deliver at 37 or 38 weeks.
So, I mean, I guess the point is here that y'all are already making changes to have a different delivery system, and we need to help put all the pieces in place so that the financial structure will be there to support these changes that you're already making.
And if we don't do something to bring these dollars down to put affordable health care on the table for this population, they will continue into our emergency rooms. We will continue to bear the cost, but we will not be getting the dollars that used to help somewhat with that cost.
Thank you very much.
Thank you.
Thank you for being with us.